welcome everyone, and thanks for coming, and thanks for the invitation to allow Unitaid to speak today. So nobody's heard about Unitaid, but has anybody heard about the WHO pre-qualification program for medicines and diagnostics? Okay, we fund that. Has anybody heard about the revolutionary diagnostic called Gene Expert? Yes. Okay, we funded the dramatic price reduction in that. Has anybody heard about the work the Clinton Health Access Initiative or Clinton Foundation does in pediatric HIV and second line? That's us. So we're the best known secret in global health, I would say, because we fund a lot of really fantastic things, and we have a really different way of looking at problems. But it is true that we don't have necessarily the name recognition of a Global Fund or some of the other donors. So thanks for coming today and allowing us to explain a little bit about who we are. So we are a WHO partnership, just like Stop TB was, just like rollback malaria. And so we are based in Geneva at WHO headquarters. We have a very small secretariat of about 65 people. We have an operating budget of about $350 million a year, and we are a donor, and we only fund HIV, tuberculosis, and malaria projects with a specific niche, which we'll get into in a minute. So we sit at WHO, we're a WHO partner, but we have an independent board that you'll see is comprised of our founding countries and major donors. And here they are. So we were founded in 2006 by 5 founding countries. That's France, Brazil, Norway, the United Kingdom, and Chile. And we were founded based upon, it was basically President Chirac who had a fantastic idea, which was to apply a small levy on flights landing and leaving from France, in which the tax would go to pediatric HIV, which in 2006 was a really neglected disease. And people thought it was such a great idea that many countries joined on, and all of a sudden there was too much money for France to handle alone. And President Chirac and President Clinton and the President of Brazil basically worked together to create this partnership at WHO called Unitaid that would be expanded beyond pediatric HIV to work in HIV, tuberculosis, and malaria. So we think of ourselves as having sort of 2 sides of innovation. One is innovative fundraising, and that is this air ticket levy has really been a game changer in terms of showing very successful ways of raising money that go beyond typical government budget support. And the second is the innovative way in which we spend that money. So Unitaid, again, works only in the 3 diseases, and we work specifically in what we call market approaches. So what we understand is that there's difficult in people accessing all of the products used to prevent, diagnose, and treat these 3 diseases of HIV, TB, and malaria. And what we try to do is to understand who has problems accessing these products, and how does the market around which these products work, so that we can potentially build or improve the efficiency of these markets and make products more available. And we'll go into that a little bit in a few slides. I'm sure by now you've all seen the estimates that WHO has come out with over the past week. And we very much rely on WHO for providing a guiding light in terms of showing us where we need to put our efforts. So the first thing we need to do as Unitaid is to understand where the access issues for diagnostic and medicines really are, in this case, in the field of TB. And what we know is that across all of the different areas, adults, children, first line, multi-drug resistant TB, there are substantial access issues, with less than half of the people who need treatment actually getting it. So that marks the first access point for us, is that there's a major problem. Then we have to look through our own lens, through using these market interventions to say, is there something that we can do? So we first identify that there is a public health problem. So we look at disease burden, disease trends, and specifically access to the products used in these diseases. And then we say, okay, very few people have access to TB diagnostic and medicines. Is it because there are market shortcomings around these products that limit their access? And we think about market shortcomings in terms of 5 different areas. One is availability, and that is the perfect drug or diagnostic just doesn't exist yet, and it needs to be developed. The second is affordability, and that might be that it exists, but because of market conditions around a fractured market or a monopoly, the products are too expensive and people can't afford it. The third is around acceptability. That is, maybe the medicine exists, but it doesn't exist in a way that's acceptable to the people who actually need to take the medicine. So one very good example is kids. And for adults, we have fixed dose combinations where you have 3 medicines in one tablet, but for kids we don't have that. And so one of the areas we try to look at is acceptability and trying to make the products more acceptable for the people who actually have to take them. The fourth area is around quality. And here we want to make sure that not only are the products affordable and acceptable and available, but they're of a good international standard of quality. And that's where we fund pre-qualification to help us with that. And the fourth area is delivery. So the product's available, affordable, acceptable, that's great, but can you get it where it needs to be so that you don't have stockouts and people, when they show up for care, actually have that product? So what this chain basically looks at then is the first area, we've defined the problem, low access to these products. The second is we've defined that maybe the product exists but it's too expensive. The next thing we do is to say, okay, what's the intervention to decrease that price? What's the intervention to increase the quality? What's the intervention to make that product more acceptable? That's a very different way of working than a typical donor that basically just funds health service delivery. That is, give money to the government to treat more people. Here we're saying there's a reason that not enough people are treated, and we're going to fix that reason around the product or the commodity so that we can help all countries and all buyers who are trying to use these products. And the hope is that our interventions would basically correct those shortcomings. The better products would be made available. The expensive products would be made less expensive and more affordable. The products that aren't acceptable would be made more friendly and useful to people who need them. The products of unknown quality or bad quality would improve, and then we'd make sure that the products actually get where they need to be in a timely manner. And if you correct those market conditions, then basically we allow everybody who wants to treat TB patients to benefit. So if Unitaid decreases the price of Gene Expert or a TB medicine, it has these external benefits to everybody who's trying to buy this, whether or not they're getting money from donors or using their own country funds or out-of-pocket funds. That's the difference of Unitaid versus other typical health service delivery donors. So how do we do our work? It actually involves an enormous amount of landscaping. So for all of the diseases and all of the markets in which we work, we do what we call landscape analyses. And these are published on our website and freely available to anybody who needs them. And we basically look at what are the issues that exist in all of the different markets, how severe are they, and what are the opportunities to change the markets to increase access. And what you'll see on our website is this thing we call the Market Dynamics Dashboard. And it basically gives you every month an updated snapshot of all the markets in which we work. So this is a snapshot of the tuberculosis market for medicines and diseases. It tells you the different niches in which we work, so adult first line, second line, pediatric for medicines, and then diagnostics. It gives you a sense of where we are in terms of global access, and then it has a severity index that shows across the different market shortcomings or failures how severe that market is. So the X's, 2 X's mean it's really severe. So for adult second line medicines, you can see double X's across availability, affordability, quality, acceptability, and delivery. We really have a failed market. That is really the reason why we can't get people on treatment. So the black full moon you see there is a composite of all the different market shortcomings that says this market really needs a lot of help. And if we intervene in this market, we can really help the world in terms of scaling up access to TB medicines. We then, from the Unitaid perspective, look to see, what's the opportunity for intervention through our business model in the short term and in the long term over the next 4 years. And what we see here is we currently have good opportunity to intervene and an even better opportunity over the next 4 years, given the amount of research happening in this particular space. One thing to note is, for those of you who maybe have some reference to the other diseases, is that tuberculosis is really difficult on so many levels from the clinical and the market perspective. And one is just the size and the fractured nature of the market. This slide basically shows relative size of the 3 markets for HIV, malaria, and tuberculosis. This is in terms of medicines used to treat the 3 diseases. So if you go across the x-axis, the length of that bar shows you the size of the market. So obviously HIV is huge, malaria is much smaller, but tuberculosis is really tiny. And then if you look within those different bars, you see all these little squares. And those are the individual products that are used within that disease. And the more of those little squares you have, the harder it is to get the markets to work efficiently. Because what markets really need to work efficiently is economies of scale. So the more you can get rid of the little boxes and have more of the big boxes like you see in HIV, that's where you get the healthier market, the competition, people wanting to, industry wanting to innovate and invest because they see a return on their investment. And so you can see from this slide how difficult and challenging the TB market is compared to the other 2 markets. This slide is very full, but what it gives you is a sense of where Unitaid intervenes along the value chain. So on the left, you have the upstream interventions around research and development. And it goes, we think of our activities that go all the way along the value chain to delivery in country on the right-hand side. And what you can see is the timeline of the different types of interventions that we've had across the 3 diseases from the time Unitaid was established in 2016 until the current phase. And what you can see is that in 2013, we started to move upstream a bit. Whereas before, Unitaid was in the beginning really about pooling purchases with CHI and the Clinton Foundation, buying more, negotiating lower prices. Those opportunities are less available now. And what we've seen is that we've had to move upstream a bit because the products aren't available in the form or price that we want them. So what we've had to do is invest in having somebody actually create the products that we want, not at the desk research base, but sort of once there's a proof of concept, we can step in and try to get the better products available sooner than they would happen if we weren't there to catalyze the market and get that uptake happening sooner than what would happen normally. So my last slide in terms of Unitaid's work in TB really gives you a snapshot of some of the areas in which we've made investments. One of the projects that we supported was implemented by WHO Stop TB and Find, and this was a project that really looked to figure out how can we better identify MDR TB cases and improve the laboratories for finding these MDR TB cases. And that resulted in about Unitaid being responsible for identifying about a quarter of the cases worldwide. The second one, which many of you probably know about, is the dramatic price reduction we were able to get with a buy down that we did in collaboration with USAID and the Bill and Melinda Gates Foundation that brought the price of GeneXpert from $18 a test down to less than $10 a test for the world. This has really had huge impact in allowing countries to scale up access to that fantastic diagnostic. The next project we funded was to the Global Drug Facility, and that was for a strategic rotating stockpile of MDR-TB medicines. Now, if you think back to that graphic that I showed you that shows the market of MDR-TB with all those little boxes, the reality is there are lots of different products used in MDR-TB. And the time from which a country would place an order and then receive that order can be more than a year. So if they don't plan ahead of time, they'll run out of treatment. So we created this strategic rotating stockpile so that nobody would have to run out of medicine. Given the long lead times that you need, because no industry is going to basically produce these TB medicines on a rolling basis. They're only going to produce them when there's enough for the orders for it to be worthwhile. We created this strategic rotating stockpile so that people wouldn't have to go without. And they could basically take from the stockpile if there wasn't medicines ready for the manufacturer, and then they get replaced once the manufacturer is able to produce and send the medicine. And this has had a huge effect in reducing stockouts. We also realized that there was no incentive for any pharmaceutical manufacturer to actually develop a kid-friendly pediatric medicine. So we basically funded TB Alliance, along with one of the pharmaceutical companies, Cipla, to develop a kid-friendly product that's one medicine that tastes okay, that has 3 medicines in one, rather than what the current practice is, which is taking adult medicines, breaking them in half or thirds, and giving them to kids. And then the final project that we most recently funded is a really exciting project with Partners in Health, which basically says what we realize in MDR-TB is that we actually don't have great regimens, great treatments to treat people. And if you look at the WHO recommendations, there are more than 50 regimens out there. With that many regimens out there, there's no way you can make that market work efficiently. We have to get that number of regimens down to 10 or less. Right now with HIV, there's one major regimen that WHO recommends for the world. And there's a whole lot more people getting HIV treatment than MDR-TB treatment. So we need to figure out how to do the same for MDR-TB and rationalize treatment and get that market focused around a fewer number of products so more people want to come in and produce it, and it can be produced at an affordable price. This is a snapshot of all of the different partners in which we work. We're just a small secretariat of about 65 people. So we really rely on our partners to implement on our behalf. So for TB, we're really looking at Partners in Health, TB Alliance, Médecins Sans Frontières, WHO, Stop TB Partnership as our major partners. Finally, 2 slides just to say, there's a lot of great work being produced and highlighted at this particular union conference around MDR-TB. We have our own satellite that we'll be holding this Thursday. We'll be presenting that work we funded with Partners in Health. And many others will be presenting some of this work over the course of the week, and I hope that you'll get a chance to hear more about all the exciting things happening in that space. And the same with pediatrics. I think this particular symposium will give you a really clear direction on the status of that project, when we can expect finally to have the first ever pediatric fixed dose combination product available, and how that will impact kids' lives. And that's my summary. Thank you very much for your attention.
We have a few minutes, so whoever has the first question, raise your hand.
Could you go through the ticketing mechanism? Is that every airplane ticket going from France to somewhere else, or every ticket going into France, and are there other countries involved?
So we have, the French. We have a number of donors. It's not just France who basically gives us funds. So, for example, our number 2 donor is the UK, and they give us regular budget funds. So our funding is quite mixed across many donors. The French situation, it's a range that goes from €1 for an economy domestic ticket all the way up to 14 or 15 euros, Sarah, for international business class ticket. And it really depends on sort of what class and type of ticket you have that dictates what the actual fee is in France.
I'm recommending that our foundation only fly business class from France, so you get the money. I think this is...
We really appreciate that.
Actually, Sumitra, did you have a question?
Yeah, I just want to ask what stages in this pediatric drug development has it already begun, and what stages?
Yeah. So the reality is my understanding is right now they actually have. It's been about a year since the project has been funded, and I think at this point they have a product physically that they've designed, and they are starting now to plan the bioequivalence studies, which is the next phase. And I think concurrently they are working with the WHO pre-qualification program to figure out what the regulatory pathway would be, because there hasn't been any pediatric products ever for TB. It's a bit of a challenge to figure out, because there's no comparison. Is there additional work that will have to be done, or can they use sort of the estimates that WHO has put out there on what they think the doses should be, and get WHO pre-qualification based upon that. So right now, we're hoping that the pre-qualification program will accept the doses that the WHO TB department has put out there, and that they'll accept the bioequivalent studies, so that we could see a product within 2 years actually being bought and purchased in country. And it will be much cheaper and much more efficient and much more acceptable than anything we've ever seen in pediatric TB.
Has Unitaid done any work on vaccines?
No. At this point, we have no mandate to work in vaccines, mostly because it's a bit too upstream for us. And of course, there's Gavi that has its own mandate to work on...
We all know what Gavi is.
The answer is maybe we don't. So.
Global Alliance for Vaccine Initiatives basically is another Geneva-based organization who has a similar mandate to us, but they work in vaccines. So at the moment, we haven't seen a compelling case, because either things are too far upstream for vaccines, or it fits in Gavi's mandate. Doesn't mean that we could never work in vaccines, but so far we haven't seen a case that really warrants our intervention.
Other questions?
Please.
Very good. Say there hasn't been any pediatric product. So what have you been for to treat kids?
They're literally taking adult tablets and breaking them in half and thirds and quarters. Even when they're not scored, they don't have the line in the middle to break them. People have really been struggling to treat kids. You'd be really surprised and saddened to see what a kid gets for pediatric treatment, because there hasn't been any attention on pediatric TB. It's been a real problem to diagnose, it's been a real problem to treat, and part of the reason we haven't been able to treat kids is we haven't had the right product even to treat them. So that's what people have been doing. They've been taking an adult product and trying to figure out how do you get a third or a quarter of that adult tablet times 3, because you need at least 3 medicines, maybe 4, to treat a kid. So you're taking a third of this, a quarter of that, half of that. It's really, really, really not ideal.
And if you're a child whose parent has multi-drug resistant TB and you caught it from them, then you have MDR TB. So the number of medications you have to take is
Even
increased
more.
exponentially, and it's a horrible situation. Anything else before we release Brenda?
Having worked on, let's say, new generations of medicine, experimental medicine, I'm from Georgia, and my government is going to test and use some new generations medicines against multi-drug resistant TB. And I have some information how they work, how they useful, and
No, it's a good question. There's a lot of great research happening around, finally, new products for MDR-TB after so many years of no research. We don't fund new clinical research, so we don't fund discovery work the way the NIH or Bill and Melinda Gates Foundation or others fund it. But what we are funding with the Partners in Health Project is these new generation of TB medicines that have just been approved by the FDA and EMA, but we don't yet know how to actually implement them in practice. So they've been approved by the regulators, but actually nobody knows how to implement them in a safe and effective manner. So what we're funding Partners in Health to do is to figure out how do you take that new generation of great product and actually bring it to where it's needed in the most efficient manner. So we can do that type of implementation science, but not the discovery end of finding new molecules.
I think that's very interesting. That might make a great story for someone to talk about what is the pathway between discovery and approval of a new drug to getting that new drug to people. And you have to talk about who will manufacture it and what do you need in order to make it? Is it created in chicken eggs, or so how do you make it, and then how do you store it, and how do you get it to where it's needed, and does it have to be refrigerated on the way, or is it a powder that can be mixed with water, and is it going to a place that has clean water? I think there potentially, for some of you, depending on where you are, interesting stories around that process. So thank you very much.
Thank you very much.
This was great.